Coming back to the geriatric internal medicine practice clinic, Mary, what's your approach to setting up the evaluation process? Who do you get involved? How do you explain the process? How do you monitor it?
Yeah, I think it's very important to establish a strong team, and I talk with my patients about that, saying, hey, I'm on your team. I'm going to walk this walk with you. We both have concerns, and the first thing I ask is can we involve a family member, a friend, a colleague, someone who knows you well that can be another set of ears. So I mean, 4 ears are always better than 2. We all have blind spots, so it's very important as we're investigating this that we have a good team surrounding us. And then I talk about what we do to investigate cognitive behavioral concerns, that there'll be some further testing that help us determine is this normal aging or is this more an Alzheimer's or other type of dementia process. We'll also do lab testing, we'll do potentially brain imaging in most cases, and that we'll meet together at each juncture to go over the results, to answer questions, to talk about caregiving concerns. I talk a lot about the importance of the caregiver that's most involved being present to help at every juncture with both processing the information that we're sharing and also helping to develop a care plan jointly. The shared decision making and the approach, certainly it's not a one size fits all. We've got to look at each person individually.
Great. So you're setting up the goals, coming up with this triadic relationship between you, the patient, and a care partner. So let me pose this question to Mark. Mark, how do you, along the way, assess sort of knowledge, capacity, and sort of tweak your education and monitoring along the way in this process with your patients and families?
This really becomes one of the most important concerns over time, because as you're trying to manage someone, you need to know that they're able to take their medications correctly, they're able to be safe in a different environment, they're able to make decisions which make sense. And with any form of dementia, especially as it progresses over time, that ability changes, and sometimes it can be difficult to really know at what point they're really becoming more vulnerable. So the baseline evaluation is key, and this is where some form of neuropsychological testing is really going to make a difference, because you're going to be able to assess their decision-making abilities, or what we call capacity, across several different domains. There's 3 particular areas in which, whether it's in a routine evaluation or whether you're doing a little more in-depth mental status examination, that we really try to look at issue of capacity. So the first thing we want to know is, can someone really understand the topic at hand? Can they inventory what's going on, what medications they have to take, who's involved with their care? Really, do they know the landscape around them? And if someone doesn't know that, or they're really losing touch with that, already they're impaired, and everything that follows is going to be difficult. The second issue we look at is, can they reason about it? When you discuss whatever the issue is with them, whether it's managing something at home, whether it's driving, or maybe they're still at work, are they able to really engage in a discussion about what's going on in those different settings? Do they have insight into what their condition is, and can they really talk about it in a way that's meaningful and makes sense? And then finally, can they take this information and this reasoning ability and actually make decisions that are consistent over time? And there might be individuals who certainly have strong opinions and they're making decisions. They could be bad decisions, but we need to have a sense, are they reasoned out appropriately or not? And again, without doing, and this is where I think a lot of physicians struggle, because if you don't do, or you don't have the information on their overall cognitive status, it's really hard to know how they're making those decisions, and you need an informant as well. You know, Mary alluded to something earlier which is really critical, is that a lot of people get exploited and neglected and abused who are suffering from dementia, because there's no one around them to really realize what's going on. And so it might be the person who people are calling them and asking for money, and they're just kind of giving money away. Or they're having people come into their home and it's not a safe situation, or they're dependent on someone who's really not taking good care of them. So the role of the clinician here is so critical to be able to get to know them well enough, to engage with them, to know their informants and their caregivers, to assess this. I would just add one other point, that I think sometimes there's a lot of confusion between decision-making capacity and competence. So capacity is always going to be relative to certain areas. Someone might be able to have the capacity to say, I want to do X, Y, or Z, and not have the capacity to make other bigger decisions, so they might need help with it. Competence is something that's a legal term. Judges determine that. So we work with people all the time who, you know, they have variations of their capacity to make decisions, but they're still technically and legally competent. And those are also important things to address, because sometimes, often family members will come to us and they're really concerned about someone's situation, and yet there might be legal barriers to really getting more involved. And so we try to work with the person and the family to try to make certain that at the end of the day they're safe and they're getting good care.
Yeah, I think that's a really some really good points. And I think, Mary, you alluded to the fact that one of the things that we have to, as clinicians, safeguard is making sure that what we're doing isn't harming patients. So managing their medication, so they have the capacity to manage their insulin now. Do they have the capacity to, take their blood pressures and the right medicines in the right way? So I think that's another big point, that really the onus is on us as we're giving them things that can really harm them, that we don't become a vehicle for that. So that's really important.
And I think the other thing that I find too, in choosing that care partner that's going to be in this process, is it may not be the patient's spouse.
That's
right?
true.
And we also, oftentimes I see, as I begin to involve other people in the evaluation, that they perhaps have some impairment themselves. And so I think that part of that early process of deciding who's on your team, and when we involved, your daughter is in California, that can conference in by phone call if they can't be there. I think that's probably one of the biggest challenges in a primary care practice, is taking the time to make sure you have the right people on your team.
That's so critical, and making certain that you have social services at your fingertips, because you might be meeting with the person and the daughter is on the phone from California, and you realize this person can't take their medications. The daughter's in California. Who is going to help them, and who's going to help them that evening? And that's a big challenge. But if you have individuals that you can call upon, services to call upon, it gives you that sometimes urgently needed safety net for someone.